So my name is Gagan Singh. I'm an interventional cardiologist and structural cardiologist at the University of California, Davis Health in Sacramento, California. I kind of specialize predominantly in structural heart procedures involving the mitral and tricuspid valves, and then also left atrial appendage closure. To back up a little bit, TRILUMINATE is looking at therapy for patients with tricuspid regurgitation. And tricuspid regurgitation has always been kind of this kind of, bastard stepchild, if you will. It's a disease. We don't really have anything for it, so we'll just not bother with it. And I think having a therapy now for a heart valve disease really allowed us to look into it and to see, hey, what is the anatomical considerations? What are the clinical considerations? And then how does it impact patients? And we see these patients and they're suffering. They have really bad right-sided heart failure. They have chronic symptoms. They live just a miserable life. So TRILUMINATE, the early series, showed that, hey, listen, it was safe. We could put it on successfully, these clips, and patients did okay. And then the pivotal trial, which you're referring to, was really the first of its kind. It really was a groundbreaking, landmark clinical trial that really has now paved the way for a huge multi-billion-dollar industry for tricuspid valve disease. And so TRILUMINATE is now, for the first time, it answers the question, if you just leave these patients alone versus if you put clips on them, can you impact their quality of life? Can you keep them out of the hospital? And that's what this trial answered. The study design was a randomized trial, so it was patients who had severe symptomatic tricuspid regurgitation, who had been optimized on medical therapy, and this is adjudicated by heart failure physicians. So a lot of patients had to be on diuretics, high doses of diuretics. They had to be on mineralocorticoid receptor antagonists. They had to be on Jardiance or SGLT2 inhibitor. And after all of that, they underwent hemodynamic studies. And these patients could not be decompensated. They had to be fully optimized. And then they had to undergo transesophageal echoes to make sure that they had anatomy that was suitable for the clip procedure. And after you went through this very rigorous screening process, then basically those patients were then randomized to either medical therapy or they received the clip procedure. On average, patients were in their 70s to 80s. 90% plus of them had atrial fibrillation. At least a third of them had prior pacemaker leads. So overall a very sick cohort, many of them with class 3, class 4 heart failure symptoms. Yeah, the 2-year data is really just, I think, something that's again groundbreaking. When we looked at the 1-year data, what we saw was that there was quality of life improvement, and there was a lot of debate about that. Is that meaningful? Does that really impact the patient? Does that really impact payers, especially insurance companies? And so that was a lot of debate. And now fast forward a year later, not only do we have sustained improvement of quality of life metrics, not only do we have sustained reduction in tricuspid regurgitation, but now we actually have reduction in heart failure hospitalizations, which is I think a big deal, because we come from the aortic world, the mitral world, we're expecting changes within the first 6 months to 1 year. This is a very different group of patients. They're not immediately dying from tricuspid regurgitation. They're just living a chronically miserable life, and it's a very, very slow process. So at 2 years, the trial now shows that these patients, actually, we can keep them out of the hospital if they're treated with the tricuspid clip procedure. There was a 28% reduction in heart failure hospitalization. And what we focused on in the presentation here at EuroPCR was predominantly looking at the control patients. A lot of these control patients, if you leave them alone, and this is for the first time ever, we now have natural history data on tricuspid regurgitation in a clinically adjudicated and an echo adjudicated manner. Nobody's ever done that before. And what we're finding is that if you leave patients with tricuspid regurgitation alone, that they do progress even as early as 1 year. And their TRs, regurgitation gets worse, their symptoms get worse, and you want to catch them before they get too far gone. You got to take TR seriously. If you have tricuspid regurgitation and the patients have symptoms, you can't just sit on it. That's kind of the key take-home messages. What we're also learning, and now with 5+ years of experience in the tricuspid space, we're not just targeting patients to just moderate regurgitation or less. We really need to get them down as low as possible. We need to identify these patients faster. We need to get them on medical therapy sooner. And then if they are candidates, to offer them therapy sooner. And I think those are some of the key messages, key clinical implications, is that we just can't sit on these patients for that long. Yeah, that's actually the million-dollar question, which is, hey, clinically, what are these patients going to look like? So in the TRILUMINATE clinical trial, the pivotal trial, patients either got treated with the device right at time point 0, and those are going to be followed out to 5 years. So we'll continue to analyze those patients and follow those patients and see how they're doing. At 1 year, patients were allowed to cross over. Of the crossover patients, about a quarter of them, of the patients that crossed over, a quarter of them had heart failure hospitalizations. 3/4 of them had progressive symptoms. So now these patients have been treated, and we're going to follow them out for another 2-3 years. The question is, can we restore them to the same level as these patients who were originally treated with a device, or did we lose precious time in that 1 year? So that's going to tell us on that if we can actually get to these patients ahead of time. And then there's about a little under 50 patients that are so far still in the control arm and are not treated. So the question is, how do they do at year 2, year 3, year 4, year 5? I think this is going to be important because there's not just TEER therapy, there's replacement therapy, there's all these other non-alternative, non-repair or replacement therapies that people are working on. And I think people are recognizing that A, it's a problem and you cannot sit on these patients. And that's what the ongoing research will help us identify.